So I am pleased to introduce Lois Wessel, who is a family nurse practitioner at the community clinic and Celebremos la Vida. How about that for some poor Spanish? Please forgive me. And that is a cervical and breast cancer screening program at Lombardi Cancer Center at Georgetown University. Ms. Wessel is an associate director for programs at the Association for Clinicians for the Underserved, an advocacy organization which promotes the training of healthcare teams to improve the health of underserved populations. She has designated and delivered training modules for chronic disease management, health literacy, group medical visits, integration of community health workers in medical teams, medication management for patients with limited English proficiency, and the use of medical interpreters. She is bilingual in English and Spanish and is a trained medical interpreter and teaches in interpreter training courses. So I'm pleased to pass over the mic to Lois.
Thank you. It's definitely a pleasure to be here, and I feel a little overwhelmed having such a big room, and I'm glad all of you are here, but I also see a lot of empty chairs. So don't hesitate to move forward if you want so we can be a little more intimate. When I saw grand ballroom, I thought, wow, they didn't tell me I was the plenary speaker. So here we are. I think this is a good discussion after what we heard this morning about a lot of the really exciting changes that are going on in healthcare through healthcare reform. And I think that one of the things that we're all really looking at is how to improve the quality of care, so we've improved outcomes because we know we're not doing a very good job right now, how to address things like cultural competency, health literacy, the intricacies of chronic disease management, and something else that isn't often touched upon but is near and dear to my heart, and that's provider wellness. I think healthcare providers in community health settings get overwhelmed with everything that we're required to do, the use of electronic health records, work towards patient-centered medical home, addressing health literacy and cultural competency, hitting all of our screening and prevention goals, and all that in a 15-minute medical visit. And you do want to get home at the end of the day to see your own family. And so in talking about diabetes group visits, I think it's something that really addresses disparities, cultural competency, provider wellness, and ultimately improved outcomes. And when we talk about group visits and health literacy, I would like to couch that within the framework of the patient-centered medical home.
Popping up, yeah. Do you know how to pop this up here? Yeah.
Because I have really good pictures on my slides. I don't put words on my slides.
Does anyone know how to pop this up on the screen? Anyone can be helpful for us? Okay.
How about sometimes?
You guys in the back, do you know what I need to do?
Yep, got it.
There we go. Thank you.
Good. Okay. So I'm not going to spend a long time on patient-centered medical home. There's some specific sessions just on that, and I think it's a term that many people probably are familiar with. But patient-centered medical home is a designation that clinics can apply for, which focuses on improved access to care, coordination and integration of care, improved quality and safety, and a whole-person approach that looks at language, culture, literacy, and probably what's most key is self-engagement. In other words, how can patients learn to take care of their own needs? And it looks at each member of the healthcare team practicing to the top of their license. So as a nurse practitioner who speaks Spanish, I shouldn't have to be filling out forms that are in English that my patients can't understand, because I could be better utilized diagnosing and treating and working as a nurse practitioner. So why do we even care about a patient-centered medical home? Well, we want to improve quality, we want improved outcomes, we want improved payment so that our community health centers and our work with residents of public housing can improve. We want improved documentation to see where we're doing what we should be doing correctly and where we still need to work. And again, we want improved patient and provider satisfaction, because I don't think there's anybody who's a patient or anybody who's a healthcare provider these days who says, oh yeah, accessing the system is really easy. Oh yeah, my doctor pays really good attention to me and I get all the time in the world. Or healthcare providers say, oh yeah, healthcare reform, I don't need to worry about that because we're doing all the right things. Everybody's a little bit frustrated right now. So some of the patient-centered medical home standards, and I'll tie this in a minute to the group visit model, talk about accessing. Can you get care when you need it? population management. Are we not looking at individuals, but looking at the health outcome of populations? And that's really key when we talk about patients who access care through a public housing primary care clinic. And that's because if we're looking at, there are high rates of diabetes in this community, or high rates of asthma in a certain zip code, in a certain area code, in a certain block, in a certain building, and then what are interventions that we can target to populations? We look at planning and managing care so that we're not reactive. Too much of our health care is people go when they're sick, or we see them when they come in for a sick visit and we can't take care of their prevention, like their pap smear, or sending them for a mammogram because we're working on the sick visit. And as a healthcare community, we are looking at taking care of them when they come into the office, instead of looking at how do we care for them before they come in so we know the best things to do. Do we understand what are community resources and how can people best engage in self-care or self-management? Are we doing quality improvement measures to see as a whole, are our patients, in this case with diabetes, having better benchmarks? Their hemoglobin A1Cs, which looks at their diabetes control over 3 months, their blood pressure, have they had their feet examined? Are we looking at that in terms of a whole population? Again, because if these quality improvement measures are not being met, it's not just poor outcomes for the patients, it means that the healthcare team is not doing the right thing, and so how can we intervene and work with the team? And that's part of patient tracking. So moving on from there to talk specifically about diabetes, I don't think there's anybody who doesn't know that diabetes is a huge problem, and I have to be totally honest. One of my pet peeves is all the medical conferences I go to that serve Coca-Cola, including this one, and I hope Astral doesn't kick me off the platform for saying that, but I think it's a chronic problem that there's a lot of sugar in our diet. There's about 24 million Americans who have been diagnosed with diabetes, and that's those who have been diagnosed. There are many people who are undiagnosed. I used to work on a mobile health van that provided health care to Hispanic day laborers, and we included a random blood sugar as a vital sign. So everybody who came in got a blood sugar. And often they came in saying, I think I have a urinary tract infection. I'm peeing all the time. And we would do a blood sugar test and found their blood sugar to be quite elevated. And we'd say, well, peeing might be a sign of having diabetes. Have you ever been tested for this? And that was the first indication that they might have diabetes. In addition to the number of people who have diabetes, diabetes accounts for 25% of Medicare expenditures, and that number is rising. Again, we're looking at how to reduce health care costs. So in order to reduce health care costs on diabetes, we need to improve our diabetes care. There's been $174 billion in direct and indirect costs for diabetes care per year, and that doesn't include certain complications like the need for dialysis or amputations. It's the 6th leading cause of death in the United States. And so there are many reasons that we need to look at improving our diabetes care, because people are living with diabetes that's uncontrolled instead of controlled. When we think about diabetes in terms of health literacy, one of the tenets of health literacy is to look at words and how many syllables they have. And I know when I was a nurse practitioner student at Unity Healthcare in DC, which is a large federally qualified health center, I had a patient come in once and said they had the virus, and I just assumed it was the upper respiratory infection that was going around, and they had HIV/AIDS, and they called it the virus. They didn't call it HIV, and I didn't really understand what they had. The next patient came in and had sugar, and I'm thinking, what is sugar? I've never heard of this disease, and they had diabetes. So often our patients don't even call it diabetes, and there's a lot of myths. I had diabetes and I took garlic and it went away. Or I finished those pills that you gave me and it got better, just like when I did have that bacterial infection and I finished the antibiotics, I got better. That's a conceptually very hard thing. Some diseases do go away when you take the pills, and some diseases are chronic, and the chronic nature of diabetes is part of the problem with health literacy. And then diabetes is filled with words that, again, have multiple syllables. This was one definition I found, and insulin. Well, people only think of insulin as something you inject instead of understanding insulin as something that we produce. Insulin is the hormone. For a lot of people, when you say, what's a hormone, they think about two things. They think about hot flashes and their need for hormone replacement therapy because they're miserable. And they think about the steroids that athletes take for which they get kicked out of sports because they've been using hormones. They don't understand that there are good hormones in their body that are part of insulin. So again, this definition regulates. Those are concepts that are very difficult to understand. The National Assessment of Adult Literacy found that 71% of adults older than 60 had a difficulty using printed materials, and that 80% had a hard time understanding forms that they were given, and 68% had difficulty interpreting numbers and doing calculations. And we talk about health literacy, but I think it's important with diabetes to think about numeracy and how crazy the numeracy is. We talk about a hemoglobin A1C, which is a percentage number that we like to be lower than 8, but some people's go up into the teens. And we talk about blood sugars that may be, again, in a healthy diabetic, between 90 and 140, but they can go upwards of that. And those two concepts relate to each other, but they're very different scales. The dosing of insulin in terms of units. You know, I have people tell me I'm on 2 milligrams of insulin because they're used to everything being in milligrams. So we have a lot of numbers in diabetes, and in addition to that, it's carb counting, calories, how much sugar is in something, how much fiber. So in and of itself, it's very confusing. Another thing I was going to say about numeracy, but I'll get back to it. So when we have a patient who's diabetic and we talk about the need for diet control, getting their eyes examined, a dilated eye exam before the next visit, seeing a podiatrist about their feet, getting their hemoglobin A1C and their LDL, in other words, their blood sugar tested and their cholesterol tested, and bringing in their blood glucose monitors from the machine that you've given them that's written in a language that they don't understand or it's very complex. And by the way, I want you to come back in 1 month and have this all done, and you have no transportation, and you're a grandma, and you're taking care of 4 kids, and you're trying to hold down a job, and one of your sons has been very sick with depression, and I'm giving you a laundry list of 25 things to do within the next month. You are overwhelmed. This is a lot of information. And then as a provider, when these patients come back, we say non-compliant, as opposed to looking at what were the barriers in the health system that made them non-compliant or made them unable to reach these goals. And the piece I was going to bring up before that I think is very interesting within the framework of health literacy. I always say that my target audiences are my patients who are mostly public housing residents, homeless, and Hispanic immigrants, my husband who's on multiple medications for chronic disease, and my father who is a 95-year-old retired physician. And I look at how all of them interact with the system with respect to health literacy. So I have access to my father's patient portal on my iPhone, and his last hemoglobin A1C was 6.7, which is a beautiful number for a diabetic. Most people would be very happy with that number. And it said abnormal. And it really isn't abnormal, especially for somebody who's 95 years old, and we're not worried about him being on dialysis in 20 years or going blind in 20 years. In fact, we're worried about him being a little bit, I thought that number was a little too low because I don't want somebody with dementia and who's shaky on his feet to fall and hit his head and, and have other problems. And so when we talk about health literacy, I think it's really important to think it's not just low-income patients, but it's really all of us, and I even put myself in that category. If I were sick with a brain tumor and people were talking brain tumor speak around me, I would have no idea what they were talking about because that's not an area of healthcare that I'm familiar with. So how does all this relate to group visits? If we think back a minute to the issue that I talked about with patient-centered medical home, improving contact with community resources, identifying and managing populations, planning and managing care, group support, community support, tracking care, quality improvement, and looking at the future of giving health care. As a healthcare provider, when I'm in a room with a patient, I frequently give a spiel about recommendations for improved care for their chronic disease management. When I'm really doing my job and when I'm going over those 15 minutes I'm allotted, I do something that's very essential to health literacy, and that's teach back. Tell me how you're going to take your medicine. Well, I'm going to take one at night, and then I'm going to take one about midnight because I work the night shift, and so I have weird sleeping hours. And I'm thinking they're taking one at 8 o'clock at night and one at midnight. That's probably not so good. It needs to be 12 hours apart. And so I'm assessing their health literacy and intervening some more so I know they're taking their medication correctly. Well, that takes a long time, and it's something it's really almost impossible to do. And so the group visit model as a template for the future really looks at addressing health literacy within a group format. And you may have heard about these group visits as shared medical appointments. Some places call them drop-in group medical appointments, which one of the tenets of patient-centered medical home is access. And some places actually have drop-in visits. You can show up anytime to be part of any time within reason, any time at 10 o'clock in the morning, any day of the week at 10 o'clock in the morning for a diabetes group visit. So what are group visits? Well, let me first tell you what they are not. They are not an educational session where somebody stands up and lectures and say, you're diabetic, you need to do this, you need to do this, you need to do this, and you need to do this. Because that format doesn't work. It doesn't give the users a chance to express what their concerns are, what their barriers are, what they need to know about. And I think that that's a huge challenge for healthcare providers. We are used to thinking we know everything. The format we're comfortable with is standing up and lecturing. One of the projects I'm working on right now is a HRSA-funded diabetes group visit program at a family practice residency program that's run by Georgetown University. And in addition to the great outcomes for the patients on these group visits, part of this is a teaching program for the residents to understand about group visits. And it is a huge challenge to get them to stand up and not to lecture. And so the key about this is it's not a lecture format, it's a shared medical appointment where everybody can ask questions. And one of the beauties of this is everybody has a question that they're embarrassed to ask, and it may be, how do I use my insulin when I'm at a restaurant? Or I'm traveling on a plane and am I allowed to take my insulin in my carry-on luggage with me? Are they going to take it away from me and then I'm going to be on my trip without insulin? I'm going to El Salvador for 3 months. Can you give me enough insulin? And do I need to keep it refrigerated because it's really hot there? And people have a lot of questions that other people may have that they may not have even, or questions that other people may not have even thought of. Some of the early work on group visits, which has been really interesting, and maybe some of the health centers you are all from are practicing this, are on pregnancy group visits. And one organization that's done a lot of work around this is called Centering Pregnancy. One of the things that came out of the Centering Pregnancy that was really exciting was that women who were together for about 9 months and got their pregnancy education and got to ask all sorts of questions about what they could and couldn't do and how to take care of themselves when they were pregnant, didn't want that group to come apart after their babies were born. And that led to Centering Parenting, which brings parents of young babies into a clinic for the 2-week appointment, the 2-month appointment, the 4-month appointment, and all the required pediatric appointments when the babies are getting their immunizations, and in some places, the 6-week postpartum visit for the mom. So these groups become bigger than just the information and almost support groups for patients who may have them. Another important thing is that this is part of a team approach to healthcare. As I kept saying, I can't do it all as a nurse practitioner in the room, but my certified diabetes educator is great. My community health worker is great. My patient, who used to have a hemoglobin A1C of 17, which means their diabetes is out of control, is now the spokesperson for how to take care of their diabetes, and frankly can say it in a way much better than I can because has lived it, has done it, knows where in the community to get the healthy foods that we've talked about. So this sounds really fun. Gee, bring everybody together. People love to talk about their problems, support network. Why show me that it works. And one of the things that we need to look at with healthcare reform is how does this all work? So there's been several studies that have looked at group visits, and it's really exciting to me because every time I kind of look at this in a search engine, there are more and more studies on it. But a couple that I wanted to bring up that I think relate to people who live in public housing was a group of people in Philadelphia. Their study was published in the Journal of Urban Health, and they brought people together for a 6-month period of diabetics, and they found that across the board, the blood pressures came down, the hemoglobin A1C, again, the 3-month test that looks at their blood sugar levels, Their cholesterol came down. The attendance initially was a little bit funky. People didn't come. People didn't show up. By the end, everybody was showing up because they heard about it. There was another study done in Cook County in Washington State, which looked at improving access to diabetes care in a group visit format. And they found that more people went for their dilated eye exam, which can indicate whether they have diabetic damages to the eye, and if caught earlier on, can be halted. And fewer people had foot problems, which, as you probably know, can lead to amputations. And there are many more studies that look at this, and more continuing to come out. So I wanted to just reiterate that what makes this different than a regular appointment? And I think one of the things that, in addition to people being in a group and learning from each other in a group and taking some of that burden off the provider who may not have the cultural competency and language skills and health literacy skills, it is also a way that clinics can more efficiently see patients. If every patient I saw with diabetes just needed the care of a heart exam, a lung exam, looking at their eyes and looking at their feet, I could see diabetics much more quickly. And guess what? And this is the key to all this. The clinic could bill, instead of seeing a patient every 15 minutes and me feeling unsatisfied and the patient's feeling unsatisfied, I could see patients every 10 minutes and we could be billing for those visits. And I think that's a really key point to this, is that this generates income for community health centers to see more patients. One of the things that scares me about the Affordable Care Act, and I was thinking about that during some of our presenters this morning, is it's already really hard to get an appointment in my clinic. The wait list is way out there. People cannot get in when they need to be seen. I say I want to see somebody in 3 months, they get a 6-month follow-up, and that doesn't really work well. If we can see people more efficiently, we can see all these new people are going to be covered, that would be key. The other thing is it looks at new ways of providing health care. For too long, we've really looked at it's the doctors and the nurses who have all the answers, and everything must channel through them. When we often don't have the answers and don't have the skills to talk to people in the community and don't have the experiences and don't have the time. One of the groups that this brings in can be a pharmacist, community pharmacists. Pharmacists who work in 340B clinics love to do patient education. There's a guy in my community who works at a local pharmacy chain. He is Ethiopian. He speaks Amharic. I live in one of the largest Ethiopian communities outside of Ethiopia. I don't speak Amharic. I have a lot of Ethiopian patients. So I brought him in for the diabetes group visits. He was ecstatic because, frankly, they don't want to just be behind the desk and processing insurance claims and counting out pills. They want to be engaged in the community. He felt like he was doing something for his patients. I felt like he was doing something I couldn't do. He provided care in a culturally and linguistically appropriate way. He could talk about foods, the way to cook Ethiopian food, healthier. It was a win-win situation. Certified diabetes educators, community health workers, medical assistants. Medical assistants want to do more than just take vital signs. Mentoring and training medical assistants to provide some of this care is really key. I touched on earlier, part of the patient-centered medical home is pre-visit planning. One of the things that I find interesting is when we go to the supermarket, I at least try to make a list of everything I need. My husband, who's even more type A than I am, categorizes it. So everything in the dairy department, everything in the fruit and vegetable department, everything in this department, so that he doesn't miss something and have to run back. I'm not quite that good, but we spend a lot of times pre-planning for many things that we do, but we don't, as healthcare providers, pre-plan for a visit. So if I don't pre-plan for a visit, the first part of what I'm doing in the room with a patient is going through their medical record. And when was their last A1C, and what's their cholesterol, and did they have a pap smear, and there goes half the visit. One of the things that's key and essential for diabetes group visits is pre-planning visits, and that's part of planned care. This does not need to be done by a provider. It can be done by a nurse. It can be done by a diabetes educator, and they can come up with a sheet for every patient of what they need. Guess what? This person's A1C wasn't done when it should be done, even though you put the order in. We can do it today. Guess what? This person had a referral for a podiatry and they didn't go. Let me call them up and find out what the problem was. Gee, the problem was there were no buses that go to that podiatrist. Let's do another referral and let me help you find the bus route. There are many different components to the reasons why people can't access their health care, and it takes time to figure out. And so if we want to improve quality, we need to help people get to the steps to get to their appointments. And so part of the group visit is pre-planning visit per patient to make sure that things have been done. If the labs haven't been done and need to be done, can those orders be placed in the system ahead of time? And ideally, call the person up, say, gee, we'd like to have your lab work so we can discuss it in the group visit. Can you come in on Wednesday? We'll have the results back by Friday. And on Monday, when you're at the group visit, we'll be able to talk about that. So pre-visit planning is key to part of this. Whoop, wrong way. One of the other things that's key is understanding medication management. I'd like to believe that there's great interoperability between electronic health records, but there's not. I had a patient recently who I used to see on the mobile health van, and I stopped working in the mobile van in part because they lost the contracted deal to provide care to the homeless, and I liked my homeless population, and so I went to a community health center which got the contracted deal with the homeless, and I had a patient come in who was diabetic, and I said, gee, I just don't remember the medications you were on in that when I saw you on the van. And he said, he calls me Mrs. Superman because he thinks my name is Lois Lane. And he said, Mrs. Superman, can you explain something to me? And I'm like, sure. He said, why is it that every time I go to a different facility, everybody puts something in a computer and none of those computers are talking to each other? And so here was this lovely homeless man who like hit the nail on the head and was able to pinpoint the problem that we're all dealing with. So one of the things that happens is because of fragmented care and people go to emergency departments, maybe going to different safety net clinics, some of my Hispanic patients have two different names in the same electronic medical record, and we're sort of treating them as two different patients because nobody's ever realized that the charts need to be merged. One of the key things is reconciliation of medication. We want to make sure that our diabetics are on an ACE inhibitor, which will protect their kidneys. We want to make sure that somebody didn't put them on insulin, and the insulin had to be acquired through a patient assistance program. In the meantime, they were still on pills, and somehow that they're doing both, and they shouldn't be doing both. Again, reconciliation of medication takes a long time in the medical visit. So if that can be done as pre-visit planning, that is key. Also understanding what over-the-counter medications people are on. People forget that things like cough syrup that they may be taking are in a sugar base, and so it may be affecting their diabetes. Or many other medications that they may be buying over-the-counter might be okay, but they're not in our med list, or may be not so good. In addition to this, alternative medicines, herbs, etc. So I've talked a lot about what we need to do with the pre-visit planning, but I wanted to point out that some of this involves patient responsibilities as well. Many places ask people to do a brown bag, which is bringing all your medications to the appointment so people can be clear what you're on. Bringing glucometers. I often have patients who have glucometers, and I say, well, tell me what your numbers are. Oh, they're good. What's good? You know, the good ones. I'm like, well, can you give me a number? No, I forgot. Well, that's a health literacy issue. They're not understanding the appropriate use of the glucometer. So asking people to bring glucometers so we can walk through that, even teaching people how to use glucometers. One of the really exciting things we did with the residents at Georgetown before we started the diabetes group visits is we gave them a bunch of glucometers. We gave them directions to try to program the glucometers for the date and the time, and they spent a long time fiddling with it, and they finally, most of them got it, and we said, okay, it was daylight savings time, now you have to change the time, and they got all befuddled again, and they realized just how hard it is, especially if you have visual impairment, reading problems, and those glucometer inserts are not written in a very health literacy way, and it gave them an appreciation for how hard it is. So many times people get the glucometer and have no idea how to use it. By bringing it, it gives them a chance to learn how to use it. Another responsibility, frankly, is showing up. Honestly speaking, usually there's a 50% no-show rate, so if you want 10 people in a group visit, inviting 20 to 30 is good. Consistency, sometimes people will come. Sometimes it's something really valid. Well, that was my specialty appointment. Well, I got a job that day. Well, it was raining, and I walked there, and it was pouring rain. But keeping people engaged and coming is key. Often people use binders, so as the sessions go, there are more and more materials that are added to the binders. We have some low literacy diabetes materials in English and Spanish that are downloadable from our website, and I passed out some postcards that have the website on them. So sometimes people, as opposed to giving somebody, here's your manual, here's everything you're going to learn, week by week giving out information and having them insert it into the binders. One of the things we found was that if people keep the binders at the clinic, they're more likely to have them, but then they don't have them at home. But if they bring them home, they're less likely to bring them back. So even a reminder call a day ahead of time to bring the binders. A key one, and I think we're going to be hearing a lot more about this, is patient confidentiality. Residents of public housing are a tight-knit group, and you don't want to know everybody's business. And diabetes can lead to things like problems with sexual performance and urinary tract infections and many other problems. And so people sometimes don't like to know everybody else's business. And, hey, guess what? You know, I was at the diabetes group visit, and you know that guy John on the 3rd floor, he's really annoying. And you know, his girlfriend's getting pretty frustrated with him because his diabetes is making it not work for him. That's not cool. So really, talking about HIPAA and privacy are key. In order to show that these things work, many times there need to be questionnaires that are filled out. And again, because of the literacy issue, many of us, you know, we fill out questionnaires like the satisfaction for each session here 20 times a day. Other people don't fill out questionnaires every day, and so having staff around to help with questionnaires is really important. Having people come early often to get their vital signs done and to get blood work or anything that needs to be done is key. Another important point that is it can be controversial, but I think is really important, is to not make it just for patients with diabetes, but really to make it a family approach and family-centered. We're talking about patient-centered medical home. And for most people, in order to manage their diabetes appropriately, they need the support of their family who's going to change their lifestyles too, add more active living, exercise, change what they eat at home. And as I said before, I kind of believe everybody's pre-diabetic until proven otherwise, so that healthy living can be really key all around. And sometimes it's that partner, that coach that you need around the house that's going to help you. And so inviting families is really important. Addressing issues around language and culture. Again, sometimes, as I mentioned, the Horak-speaking pharmacist who I've brought in, a community health worker who speaks Spanish, are key because all the studies show that people with limited English proficiency have worse outcomes than people who speak English as a first language. So understanding that community health clinics need to address issues of language access, having trained medical interpreters available are key. And I touched on this earlier as a provider satisfaction issue, but if this little cartoon shows if somebody goes to see a clinician and gets a bunch of information in a language they don't understand, it's a missed appointment for everybody. The provider doesn't feel satisfied, the patient doesn't feel satisfied, and that patient is not going to get better. And I think that one of the really exciting things about group visits, in my federally qualified health center has 5 different sites, and at the site that I'm at, I am the only provider who's fluent in Spanish, and so I just cannot see all of the diabetics. I love them, but it, you know, I'm going to go crazy. And so it's really a provider wellness issue for me. So how do we get there? How do we start this? Recruitment. Recruitment can be done in a variety of different ways. Word of mouth, especially with residents of public housing in a public housing community. Something can be put up in the laundry room, posters in the elevators, saying that the diabetes group visit is going to happen, door knocking to invite people to it. Some places look at having a mixture of people whose diabetes is well controlled for them to be kind of the champions, with other people whose diabetes is poorly controlled. Some people look at people specifically who just need insulin so that they're all on the same page. There are various ways to go about it. What we did with the diabetes group visits with the Georgetown Family Practice residents is we asked the residents to identify patients who they thought would benefit, either because they were they tended to show up for their appointments, or because their diabetes was enough out of control that they thought that they could benefit from it. So in that sense, it was provider recruitment. So there are many ways to recruit people. And as I said earlier, usually at the first visit, until these get established, and then everybody wants to come when they get established, and they hear how great they were, but initially it's very slow, and often there can be 50% of people who don't show up. The first visit tends to be chaos. Nobody knows what's going on. The people who are supposedly running the group visits aren't sure. They realize they forgot the markers. They wanted to bring in treats. Somebody thought it would be a great idea to buy donuts. Somebody else said, no, 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 you can't do donuts for the diabetics. You know, we should have popcorn for them because popcorn is cheap and it's fiber and it's good, and maybe they don't make popcorn at home, or they make the microwave popcorn, so somebody else needs to run out to the grocery store and get the you know, it's just chaos. And I've seen some sessions where the first one is so chaotic, they're like, oh no, we can't do this again. It's like anything else the first time you do it. It just takes a little while to get started. Often there's an icebreaker just for people to get to know each other, setting down the ground rules around patient confidentiality, what a group visit is, encouraging people that it's their chance to speak, and reminding people that they will see a provider. So if a group visit is a good amount of time, is an hour and a half to 2 hours, they need to know that they're going to miss some of that group visit when one by one they peel off and go see the provider in an exam room. Now, I've seen places where they actually do the exam. They just take them apart in a corner. Maybe they have a little screen. People can take off their shoes, either in a group or with the provider, to do a LEAP exam, which is the exam that tests for the sensitivity on the bottom of the foot to see if there are diabetic nerve damages that could ultimately result in amputation. Some people don't like to take off their shoes in front of everybody. So it can be done in different ways, but even having a little screen that separates people is a way for the patient to still hear what's going on, even if they can't see what's going on. And some places actually do it in an exam room. Patients also need to be reminded it's a diabetes group visit. So I know that that skin rash is really annoying, but I can't see you for the skin rash right now, which is really hard as a provider and as a nurse practitioner and a family-centered provider. You know, it's what's important to them, not what's important to me, and it's really hard, and the skin rash may be sort of related to the diabetes because fungus like sugar, and if their diabetes is out of control, then they're... So it's challenging, but sometimes being able to have access later in the week or even later in the day. Now, some people balk at this idea of having a 2-hour appointment, but frankly, I don't know about health centers where you all work, but most of my patients from start to go, between when they get there and they fill out paperwork and they sit in the waiting room and they sit in the exam room and they wait for their labs to be done and they see me, it's 2 hours anyway. So some of that time can be utilized with a group visit. That is... that can be beneficial. And one of the barriers that I've heard from people who work in homeless shelters and public housing clinics is that there's not enough room. We don't have a place. Our only common space is where the staff eats lunch, and we can't bring the patients in there. And so actually doing it in common rooms in the public housing facility can be an asset, because you're bringing healthcare to where people are. And they love that, and it makes the transportation barriers non-existent, and it's only the team that needs to get there. In terms of workflow, this usually means what happens when they get there. So sometimes it's like an assembly line, and you have 6 medical assistants, and everybody stops and gets their blood pressure done by one, and everybody stops and goes over forms with another and gets reminded of when they need to do labs, and everybody goes to the lab and gets their labs done if they need it. And so at the beginning, it's a little bit of going through the assembly line until you get to the part where the group is talking together. And that's something that needs to be established. Some places, and I actually like this better, instead of having 6 medical assistants, each 6 doing a job, there's 6 medical assistants, and you go to the next one who's available, who can do your blood pressure, who can fill out your forms, who can draw your blood, who can call up and get the report from the podiatrist you went to so it can be screened into the electronic health record. And I think that builds a little bit more patient rapport with the community, with the medical assistant, instead of jumping around, although I've seen it done in both ways. To facilitate interaction, I really suggest sitting in a circle, and I have to say I don't like this picture, and I tried to find a better picture, and I couldn't, and it kind of looks like it's still a little bit hierarchical to me, that there is the people who are the know-it-alls who are sitting in front, and everybody else are sort of their disciples sitting around them. I really think the more equal you can make it, the more of everybody in a circle, and the role of the facilitator is really to make sure that everybody can speak. So Ms. Johnson, I know you were here last month and you saw your doctor about your eye problems, and you went and had that dilated eye exam. Can you tell people what that felt like? Because we use the word dilated eye exam. People don't know what that is. And they may, I've had patients who say, when I had my baby, it really hurt to get dilated, so I don't want to have a dilated eye exam because that's going to hurt. Because again, it's a health literacy issue, and that's their association with the word. And so soliciting discussion from the patients is the role of facilitator. And again, that's a huge challenge for people who are used to lecturing. In terms of staffing, it's okay to have a provider there. And again, I said at Georgetown, we are using the residents as providers, as facilitators, but we have a certified diabetes educator there and a nurse there. And you need to allow for staff time, and you need to allow for this pre-visit planning, which is really hard because we don't have the concept of pre-visit planning. They're just like, oh, she can do pre-visit planning. But if you think about having 20 patients that you've invited and you want to go through their whole medical record and pull up the key things and come out with a printed format, which is often a written diabetes group visit form, ideally it should be a form that's in the electronic health records, but short of that, a printed form that may be filled out and then scanned into the record. As an approach I've used, that takes some time, so allowing for group visits is key. And then having your clinician understand that it's a diabetes-focused visit on what are the key benchmarks for diabetes. And again, this is a challenge. When I get my diabetic in a group visit, I want to do all their education because I'm a nurse practitioner, and I have sometimes forget that it's really 5 to 10 minutes with me, and then they need to go back to their group session. So doing some training for the clinicians on what their role is key. And it may simply be you have many problems that we've talked about, and yes, they're all related, because we can't separate diabetes from hypertension, from depression. I mean, we're whole bodies, and we're looking at this in one approach. So sometimes it's rescheduling another appointment. Another thing that is really key, and I find this one of the most important things about diabetes group visits, is I can have a curriculum of things that I think need to be addressed. Medication, diet, exercise, specialty appointments, meaning the dilated eye exam, the podiatrist, blood sugar testing, what happens when you travel, different themes that I can have, and I can have my bag of tricks on what we're going to talk about, but I want to know what do they want to talk about next. So if we say that there's going to be 10 sessions, it doesn't necessarily go in the order that I would think is the most logical. So some time needs to be spent at the end of the appointment saying, what do you want to talk about next? And sometimes there's silence, and somebody will say, well, that machine. Well, what machine? You know, the one you want me to test my sugar when I'm fasting. I don't get that machine. You say, okay, so the glucometer, that's the machine. And then it's amazing. People will pop up and say, oh, yeah, me too. I had one. The batteries went out, and I don't know how to work the batteries. And someone else say, well, I'm using my uncle's because he doesn't use his, and I want to know if I can share lancets with him, those little pointy things. Those are the lancets, right? And all of a sudden, you're almost onto that next session. So helping them come up with what the next theme is key. And you know, this comic says, we want your opinion, we'll give it to you. And I think that's the way we've been used to functioning. We tell you what we think you need to know and when you need to know it. And this really puts the decision-making into their hands. And when you get to the class, you know, and there's some prompting. So we've talked about the glucometer, and we've talked about the medicine. Does anybody want to talk about food and diet? And so we say, oh, yeah, I don't know what to eat, and I'm going to my daughter's 15 años next week, and there's going to be all this food. And someone said, well, you know, I have this really good recipe that I got from church, and it was supposed to be, oh, well, bring the recipe. And you know, it just snowballs into more and more information. So as I said, one of them may be the glucometer visit. Bringing glucometers is key. and calling up people the day ahead of time and reminding them to bring their glucometers, because there's nothing worse than doing your glucometer visit and guess what? Nobody's brought it with them. And then what the facilitator does is kind of pipers the group with questions. So what time of day do you do this? Can you show us how you clean your finger? You know, what fingers do people like to use? And somebody may, you know, it's generally assumed because they're squishy and that's what we access, that people do the pad of the finger, but that's the most sensitive part. And you think about people who read Braille, that's where they read it because that part of the finger is so sensitive. Whereas on the sides of the finger next to the nail, it's tougher skin, and so that doesn't hurt so much to do the glucose testing there. And those are little things that come out in the visits that are really helpful that patients will learn from each other. And I think of many things in diabetes. I've touched on this, but the complexities of the glucometer are key. And I put this in here because I think it's really interesting. A blood sample is taken. Blood is put on the monitor to check glucose levels. I've seen people bring these glucometers to a diabetes group visit or to an individual visit, and there's blood smeared all over the glucometer. It's because they don't know where to put the blood. And this is really hard. There's things like, you know, our smartphones and computer kiosks where you just touch things and it knows things, or the blood pressure cuff, you put it on and the numbers just show up. Well, if the blood pressure cuff can do that and the numbers just show up, why can't you just put blood on the machine and then the number will read? You know, these are conceptual things that are really hard. This patient education material says if glucose levels are too high, insulin is administered. If too low, carbohydrates are ingested. Well, that is a big way of saying you need to eat a banana. And so the patient education materials are often way complex for people. And so, again, walking through the glucometer, and then, of course, what the numbers mean is really key, because learning what these numbers are is part of self-management for diabetes. So I had a Spanish-speaking patient once who was so proud of herself that she brought in her glucose diary, and she really did a great job of getting everything down, except it was totally
and the 512, 512, and 612, 612 are the dates that she did it. So if you look at 612, she had a 248. I mean, that's pretty high. I don't know what time of day that was. She had a 78. That's a little lower than I'd like her. And there's really no reason for her to be doing glucose testing 6 or 7 times a day, because she's going to burn out, and insurance isn't going to want to pay for the strips and the lancets. And she had a 387, but I don't really know what time of day this, you know, she was doing what she thought was the best job. And what it gave me was an understanding of the fact that I hadn't done a very good job explaining it to her. So many complex things: teaspoons, tablespoons, milligrams, units. The numeracy is huge. And so something that can be instituted in a group visit is a concept that anybody who works in asthma has seen on the Asthma Action Plan, but is a red, yellow, green, just like, guess what, a traffic light. And unless you're colorblind or lived on the moon, everybody knows how a stop sign works. And this is one of the things I learned from my husband, who's a transportation planner and bike and trail planning, is that the stoplight is universal. So you go to the most remote village in Ecuador and to some big city in Africa and Shanghai, you're going to find that the traffic light is the same colors and mean the same thing. So it's a universal concept. Do I really care if my patient's blood sugar is 45 or 53? No. What I care is that they're having these lows. So maybe they can just put a check when they're in the red zone, and red means, guess what? You're in trouble. You need to eat something. You know, yellow means it's either too low or too high, and it does take some education there if it's you know, because there's those ranges. It's a little bit too low or a little bit too high with the yellow and the red, since they're the extremes. But guess what? If I get a lot of checks and it's in the green, I know that they're doing well, and they're very proud to see those checks. So if you see all these checks in the green area, which is good, that makes your patient happier than a page full of numbers that means nothing to them. And so this can be taught in the group visit, and I see people writing away. This is downloadable for free at the Feinberg School of Medicine at Northwestern University in Chicago, and they have a bunch of other diabetes education materials, low literacy that can be queued up when a patient is in the exam room, or it can be, we're talking a lot about health technology and how to engage people through technology. So a little web link can be emailed to people. People can access it on their smartphones. Again, having people bring their medicines, it cracks me up. I have to think every time about R and N because the bottles look almost exactly the same, regular and NPH. What does regular and NPH? What I really need to know is which is short-acting and which is long-acting as the patient. One has a diamond and one has a square, and a square and a diamond are the same shape. One's just tilted. I mean, poor labeling, so having people bring in their medications. And one thing that's important about this is, at least where I live, if you're uninsured, you're not going to get on these Novolin pens and Lantus, which is a long-acting insulin. This is what you're going to get. So the poorest people, the people who are the most health problems, the poorest outcomes, get the most complicated medication bottles to read. The picture on the left is a real picture that I took of a patient who brought in a medication. And I said, well, what do you think these things mean? And they said, well, the only one I can really read is shake well and keep in the refrigerator. So basically what I do is just, shake it all up and then stick in the refrigerator. But I don't take it because of all those other directions, I didn't understand what they said. And so asking people to bring in their medications as part of the group visit is key. And during the group visits, people can learn about filling medication, little pill boxes. There's some really interesting things out there not yet covered under most insurance plans, but talking pill bottles that say, hey, you didn't take your medication, and it'll beep at you, or colors will light up, really good for the elderly, visually impaired. Other programs that have smartphone applications. Yep, yeah, I did put a picture in here. I am shocked by the number of my patients that have iPhones. I used to think that I was like the only enlightened one and was an early adapter to an iPhone, and that my patients would never have these and the digital divide was so big. I was wrong. I have patients who pull up pictures of their medications that they've taken at home to show me. I have people who email me pictures of skin rashes if they can't come in. I am pleasantly surprised and admit that I was wrong. I have people who are Skyping or chatting with their families in Guatemala. So there are apps that can be talked about and can actually be downloaded. This one is called RX Mind Me, and you can put in all your medications and it'll beep when it's time to take them, so that you remember to take them. So I think integrating technology into group visits is definitely key. Everybody needs to leave the group visit, especially the one where you talk about medications, with a list of their medications. Again, because we don't have this interoperability, so getting them to, if they have to go to the hospital to have it, if they're going on a trip that they have it with them. Ideally, it can be printed out from the electronic health record. I have to tell you, my electronic health record prints out take one POBID. My patients don't know that. That means take one orally twice a day, and it says, metformin and glipizide, but they don't know which one to take when because they're all the little round white pills. One of the things that I've seen people do that I'd like, but I'm also have my hesitation with, and I'll tell you why, is actually tape one of the pills so that they know what it looks like. My hesitation is if there are children or pets at home, you don't want them to be ingested by the wrong person or pet. The other is that generic meds tend to change. So one time it's a little round white pill, the next time it's a little triangular blue pill. It's the same medication, and that confuses patients. With the session that talks about food, bringing in examples of foods, I know that the food pyramid and the different things, the myplate.gov, is really trying to make people understand healthy eating. The reality is, unless you're a child who has one of those plates where the food can't touch, nobody's plate looks like that, because in real life, food does touch, and you want your gravy on your mashed potatoes to be on your chicken and on your mashed potatoes, because you want your food to touch because it tastes better. So bringing in actual plates of food and trying to make it ethnically appropriate. The one on the right is a Korean dish. Because I sometimes bring in plates of food and people say, where's the tortilla? There's no tortilla on this plate. That's not what my plate looks like. So having access to food, some of the diabetes educators have those great plastic food things, bringing in real food. Again, this is such an easy thing for us to think about, but people often say that a portion of meat should be the size of a deck of cards. Well, not a lot of people play cards unless you play cards frequently. Or the palm of your hand, well, whose hand? My palm is a lot smaller than somebody else's hand. And so really showing examples of healthy eating is important. There's some great resources out there. The first one is cooking for Latinos with diabetic, or it says diabetic cooking for Latinos. My pharmacist friend brought in this Amharic diabetes plate so that people could take it, put it on the refrigerator at home, share it with their family. Too often we think if something is low literacy in one language, therefore someone will be able to understand it in another language. Plain language is key. Again, I talked about sugar. A lot of people don't have diabetes. They have sugar. So having low literacy patient education materials that you can complement the group visits and hand out to them are part of this. I mentioned we have some on our website. This is just a couple of examples of what's on our website, and you'll notice the lines in there, and that's where they can add some special foods that I like to eat or some of my goals are, and that makes it more personable, and you feel like it's about you and not about somebody else who wrote this. Another session needs to focus on self-management goals and understanding labs. And one of the things that I found really fascinating is if your electronic health record, or if you don't have one, just the old-fashioned pen and paper way, graphing what the glucose numbers are, having that visual, and people can look, oh, it went high when I went to that party. Oh, it was high after I had an extra piece of cake at the birthday party. Oh, it went low that day that my check didn't come and I didn't have enough money to buy food. It gives them a sense of what all of these things mean, and that's key. Again, having them understand what their numbers mean. We throw around these terms a lot, like hemoglobin A1C, and I guess I forgot to say, just because somebody has low health literacy and they don't throw that term around, it doesn't mean that they're uneducatable. And so one of the things that I think is really important is that we say, as a diabetic, you're going to hear the term hemoglobin A1C a lot, and this is what it means, so that they begin to learn some of the medical jargon. I put this one in here because, as I mentioned, my 95-year-old father's came up abnormal at 6.5, which is really not abnormal, as I mentioned. But it said click here for more information on it, and the click to on Medline Plus for hemoglobin A1C with MPGQ didn't show up. Nothing came. It was sort of a blank page. And so we have to make sure that with our patient portals, we're hearing more and more about patient portals and patient engagement. It's really taking people to a place where they're going to get information that they may need, including videos which may be more appropriate to learn, that they can watch as opposed to read. There's a group called Healthy Roads Media that has fabulous videos in English and Spanish. And then we need to assess the materials that we're giving out. This I really liked because we asked people in a group visit to draw what diabetes meant to you, and I thought this was beautiful because at the end they could come up with a little picture of what their inside of their vessel looked like and what the pancreas did, and they used the word glucagon in there. And plus, they have this beautiful handwriting, which is so much better than mine. And to me, this was like, I mean, we talk about outcomes measurement and quality improvement, and what we're looking at is, are our A1Cs coming down, and are our diabetics getting dilated eye exams, and are we doing microalbumin urine tests to test for kidney problems, and all that is really important. But to me, this was a patient who was able to understand the pathophysiology of diabetes, and it certainly made my day. This is what I mentioned from the literacy videos that should be part of the patient portal, and this was from the Feinberg School of Medicine, short videos, 5 minutes that people can watch. And then I think you need to be really careful about diabetes information that you are handing out. I picked both of these up at a community health clinic in DC, and the first one was the old concept, and I've probably mentioned that most of my patients speak Spanish, but I think you can get the gist here. The old concept that insulin is the key that unlocks the cells to receive the sugar. And I thought about it. Who's seen a skeleton key like that in their recent lives? And who's seen a sugar cube? I mean, last time I saw a sugar cube, I was probably 10. My mother used to get them out when company came over. And so that's not a good patient education piece. The next piece shows your basal insulin and the boluses that you get before meals and how it works. And I kid you not, when I showed that to a patient, I said, what do you think this means about your diabetes? They said, it means it's okay to eat where? McDonald's. So doing patient education, pilot testing, and having information that your patients tell you what it says is really important. There's a great little comic called Fiesta de Fiasco. It was a party that was a fiasco because somebody had a diabetic crisis. It's a whole soap opera. People love it. Learning about diabetes.com has great, very low literacy, English, Spanish. I'm trying to remember if they have French. I can't remember. Has really great things, again, free and downloadable. So those are the kinds of patient information that there should be out. A lot of federally qualified health centers are really trying to move away from any patient education materials that have pharmacy, or from the pharmaceutical companies. The ones that we did are funded by a maker of a glucometer and an insulin pump, but it says something like, unrestricted grant, whatever. It's still not where I'd like it to be. And I neglected to say that the ones we have are English, Spanish, and we're really excited. We just got them translated into Haitian Creole. And so if anybody works with the Creole population, I've seen very little diabetes material in Haitian Creole. So again, in coming up with the themes that I try to make sure people understand, these are the themes we're going to take for the whole time, and you guys pick what's next. There's a great thing called a conversation map. People who work in diabetes may have seen that. You lay it out on a table, and it kind of understands how the different pieces of your life come together with diabetes. But things you may look at are goal setting, healthy eating, active living. People don't like the word exercise because they think it means putting on Lycra and going to the gym. So active living, monitoring your diabetes, taking your medication, problem solving when you travel or go to restaurants, coping, depression and diabetes, eating out, injection, how and when to use insulin. There was a group at UCSF that did a fantastic thing with their diabetes group visits. They took pictures and then made a flip chart, and the people in their flip chart are the actual people in the group visits. So their group visits have gone on, and some of the people have graduated from them. But often when they show the picture in the flip top, they say, hey, that's Jimmy. I know him. My kid played with him when he was little. And so that was a way of getting more patient engagement because they made their own materials with people who looked like them. We're going to finish up, but I just want to say that it does help to have some kind of incentives to get people to come back. I try not to use food as an incentive, but having a pedometer is something that can be done. There's a lovely woman in my community who's a diabetes educator who does work in one of the public housing communities, and she gives out salad tongs as a way of encouraging people to eat salad, and then she gives out salad bowls, and then she took people on a field trip to a farmers market. And so looking for incentives, lots of time people in the community are willing to give something. Field trips to a supermarket and getting the people who work at the supermarket involved are good. And then you do want to track your outcomes. And the biggest outcomes to track are the famous A1C, cholesterol, if people have gotten their immunizations, especially their flu and their pneumovax, if they're on an ACE inhibitor, which is a medication to prevent kidney damage, what their blood pressure is, if they've gone to the podiatrist, if they've gone and had their eyes examined. And then lastly, patient and provider satisfaction. And I can talk a little bit about some of the tools for that, but I think that is really key. But it's also important to know that many of the evaluation tools that are used are written in a level that people don't understand. This just shows people's literacy level across the world. And so if you see, in Africa, the literacy rates are really low, and you're doing this with an African population, filling out those forms may be somewhat cumbersome and complicated. So it's important to get the evaluation, but it's also important to know how to effectively get people to do the forms, and it may be pairing them up with a medical assistant or a community health worker. You don't want to pair them up with somebody who's been leading the visits, because they're going to think they need to see that everything was great, and we don't want them to do that. I'm going to skip over this one because we're running out of time. But lastly, I just wanted to say that there are ways that you can code for this and bill for this, and the only way it's going to happen is if we do get reimbursement. Something that's really exciting is there are, I can't remember the number, something like 16 CMS innovations grants right now where they're looking at group visits. So I think the more that we can prove that group visits are effective, the more we'll be able to get reimbursement for it. There's no official code. I don't want to go into the coding numbers. If there aren't people here, you can talk to me afterwards if you need to know about coding. But you can bill it as a diabetes visit, controlled or uncontrolled, and it's important to do that to get reimbursed for that. And then again, I think the patients like it, providers feel much less burnt out. They don't feel overwhelmed with asking the same question. And I think until we combat this diabetes program, and with respect to health literacy, this was something that just cracked me up at a Harris Teeter. Visit our pharmacy, free diabetes. I mean, they're giving it away. There's so much of it. And until we get on top of it, we're going to have this problem. So I said a lot, but I also like to hear your thoughts, and especially if anybody's doing group visits, I'd love to hear from you. Right. So the question was to repeat what composition of the team members is most cost effective. I think that having a nurse is important, especially when we're talking about care planning. Doing that pre-visit planning usually is done by a nurse. Having a diabetes educator, if you have one, is key. With the residents, we're using a social worker because there's so much that has to do with community resources in terms of transportation, in terms of issues around where they're buying their food, how they're getting their food. It's most cost effective to have fewer providers involved, because where providers make money are being in the room with patients. At this program I mentioned at Georgetown, we do have providers involved because it's a training program for the residents so they get a better understanding of health literacy. I think having one or two providers assigned to be in a room to do the medical appointment is key. And then it really depends on your clinic. I mean, you may have a diabetes champion who is a patient in a public housing facility who you want to bring in as an educator, or a community health worker, or a peer educator. And you may have a medical assistant who really can do all the, if you want a fasting finger stick right then, or you want the blood pressure right then, you want the blood drawn right then. So I think some combination of them. And then I think there needs to be somebody on the team who's really looking at the quality improvement and make sure that these benchmarks are being met and pulling the numbers. And that often involves some of the IT people who can actually run the numbers. And so they may not need to be present at the group visits, but they may need to be present as part of the team so they know the numbers, what kind of numbers to run on population data.
Great. Thank you.
I'm wondering how frequently you have these visits.
That's a really good question. I've seen them weekly. I think more than weekly is too much. I think I've seen them every 2 weeks, and I've seen them every month. Because diabetes is something that we look at the numbers over a period of time, I think it's helpful to do monthly, but I feel like the visits I've seen where it's every 2 weeks, it's more a part of what you're doing, and so you're more likely to show up if it's every 2 weeks. Often it's a space issue. Again, where can you get a room that's big enough? But I say every 2 weeks to a month is good, because I think if it goes longer than a month, you kind of lose some of the continuity with patients, especially, as I said, the attrition rate is really high, especially in the beginning.
Great. I think we have time for one more question. Also, if you're interested in receiving nursing CEUs, see the gentleman who's walking around. Can you talk a little bit more about replication to other diseases?
Yes, I'm very glad you asked that, David. I mentioned that I think one of the areas where group visits got their start was through these prenatal visits that then moved on to parenting visits. And I feel really lucky because the people who sort of started that concept are a bunch of midwives who moved their office from Boston to about 2 blocks from where my community health center is. So I've been able to go over there and talk to them. And they got a lot of flack initially when they started this because, it was a bunch of crazy midwives. Those midwives are crazy anyway, and they've had some great outcomes, and it's really taken off, and it's spread for a variety of reasons. And I think if you look at chronic disease management, it's very similar. It's maintenance of medication and understanding how to use medication, and this health literacy issue, people not understanding what it means to have a chronic disease. And I think 2 things that lend themselves very well, besides diabetes, the other thing is asthma group visits. And the reason why I think those 2 things lend themselves so well is because those are hypertension and hypercholesterolemia, or having too much cholesterol, are treated for the most part with pills. And diabetes, and in addition to the lifestyle changes, diabetes and asthma require mechanical skills of using an inhaler and using complex things. Different inhalers do different things, like different kind of insulins do different things. And just like I've seen people put the blood right on the glucometer, I've seen people who spray their insulin, their asthma inhalers on their chest because that's where they feel it, and they don't inhale it. And so I think asthma lends itself quite well. And I know there are several sessions at the conference. There was one yesterday with the folks from Boston, and I'm doing one this afternoon on community health workers and asthma. But I think because the key to asthma is treating the home, not treating the individual. It lends itself so well to the public housing community where there are a lot of indoor asthma triggers. So learning about asthma trigger remediation and what it's not your fault you have cockroaches in your house or you have mold. It's a bigger problem. And addressing that in a group, I think, takes some of the shame away from it. So asthma is a good one. I've seen some work around diabetes group visits, and many years ago I worked on a study on low-income women and depression, and people met in groups, and at first I thought, nobody's going to want to talk about their depression. It wasn't a formal group visit, but I thought, this is really personal stuff, but actually it was incredible. And you think of these whole concepts of breast cancer support groups or many other support groups. People like to get together and talk about their problems. So I think you could take it anywhere, but I think the most logical step after diabetes is asthma and asthma management, because, again, there's a lot of issues around health literacy. There's a lot of self-management issues and a lot of complexities around using and accessing and when you use and how you use your inhalers. Other than that, realistically, many people have diabetes also have high cholesterol and high blood pressure, and so those can kind of be woven in. I saw something, I think it's happening here at this conference. Because as I tell you, somebody's doing a session on group pain management visits. I found that fascinating. I don't know much about that, but I'd like to learn more about that. So I think we're really going to see this take off, and then certainly people of other chronic diseases that may be more in the musculoskeletal nature, like lupus or rheumatoid arthritis. That may be another thing that lends itself. And right now, I mentioned the centering centering parenting, but I think group pediatric visits as kids get older, and you're talking about all of those issues around anticipatory guidance for children that can be discussed in groups. You know, your kid needs to move up to the next level car seat. Well, how much does that car seat cost? Hospitals give away the infant car seats. It's hard to get the next level car seat for free. So those are the kind of challenges that I think we can also address. Certainly issues around obesity and diabetes. Diet management and obesity in children can also be addressed in group visits.
Wonderful. Anyone on this side of the room? Question? I think Lois will agree to stay a few minutes later if people have some individual questions. One last question.
You know, the mantra, no margin, no mission, and you can bill for some of these, but the majority of the individuals that, like I'm thinking of our clinic that would need that help are the uninsured and the what should I call it? The bad debt. They wouldn't be able to pay for it. What other organizations or what other partnerships do you have that might be able to pay or help support the services? Because you're talking about a diabetic educator, or some of the other the specialists in that team that are so important to make it successful. How do you go about continuing this?
I'm not sure I heard the whole question, so I think I got it. And that's, how do you pay for this, especially when you have uninsured patients in your patient population?
Additionally, as well as some of the additional disciplines like a nutritionist and a diabetic educator.
Excellent question, and that's why these CMS grants to show that the outcomes are important are really good. I know that many places that managed care payers are doing it. I don't know if there's anybody here from the asthma group, visit group. I think they're speaking here from Boston, but I know that in Boston and in Rhode Island, they've gotten the Medicaid managed care plans to pay for some of this as demonstration projects, and they've demonstrated the return on the investment on asthma, specifically with reduced emergency department visits, has essentially paid for itself. But I also think having a mixed group where you have uninsured and insured helps. It's very challenging. I always say that most of my patients are uninsured and uninsurable because, frankly, they're undocumented Latino immigrants and they're not going to be covered under the Affordable Care Act. But really talking to the Medicaid managed care plans to try to do some kind of demonstration project and compare with other states what they're doing is key. For the diabetes group visits at Georgetown, we were able to get HRSA funding to do a pilot project, as well as some money from the American Academy of Family Practice. Again, it helped that we were training residents, and so that was kind of like a buy-in. But looking at local organizations that are essentially paying for care and even grant funding, all that may be key. But we're not yet there on payment issues, and I think that really getting the Medicaid managed care plans to pay for that, because as you said, the certified diabetes educators and the social workers and the nurse, not only are they unreimbursable, but it's taking time away from other patient work that they may be doing at that same time. But again, if you think about 20 people in a group with a certified diabetes educator versus one 15-minute appointment, you'd have 8 people over 2 hours. And so you really are getting more people for the same amount of time.
Thank you so much. Just a reminder also to complete your post survey, and you can leave them on the table and someone will come by and pick them up.